Hi, everybody. My name is Marat. I'm a heart failure cardiologist at Duke University in the US, and I'm joined today by Dr. Duncker from Germany to have our second part of the series to talk about sudden cardiac death risk in the GDMT era, rethinking protection. And today we will be tagging on to our prior introductory discussion of the SCD-Protect trial, which has been since then actually published. And we'll be discussing in greater detail the manuscript that was published in the European Heart Journal just a couple of weeks ago. Welcome.
Yeah, hi Marat. Happy to join you.
I'll maybe just to recap what we ended last time, which was about a month ago or 2 months ago now. We talked about how sudden cardiac death risk is really something that seems to be primarily temporary in nature, meaning that the highest risk of sudden cardiac death tends to follow the early time frame following the acute event, whether it's an MI or new onset non-ischemic heart failure, and is clustered around the first few weeks post-discharge. And that risk then tends to bottom off pretty quickly, particularly in the era of GDMT. We've seen a decrease of sudden cardiac death risk, given all the great benefits of the 4-pillar therapy that we have at least now. And we have a couple more pillars that might have been added since ESC to that bucket as well, with the Joxin and Versigwat. So I do think that the chronic risk, once you're on those drugs, tends to be actually relatively low. Having said that, it is your study, and we'll recap it here, that indicated that the risk might be actually quite high, particularly in early phase. This is the summary figure around the content of this. And I'll just, we'll start from the left and go to the bottom right, work our way through this study. So why don't you tell us a little bit why this study was done again, the SCD-Protect study, and what the makeup was of the data gathering?
Yeah, sure. I think this is an important point, and you already mentioned that apparently we had a discrepancy between the long-term risk and the early risk. And we have to admit that the data we really had on this early phase was really low. Even the Valiance study that you showed included patients only some days after MI. So this was not exactly the early phase, and the incidence of sudden cardiac death in this phase was largely unknown. So what we intended to do, and this is really new, is to include patients that received a WCD in the early phase after newly diagnosed heart failure with a reduced ejection fraction, either due to non-ischemic cardiomyopathy or after MI or after diagnosis of coronary artery disease. And they correspond to a patient cohort that, let's say, newly diagnosed heart failure, and after wearing a WCD, we could then really estimate the sudden cardiac death incidence in this phase. Now, the method was including all WCD patients of Germany receiving this WCD between December 2021 and May 2023. And this was really consecutive enrollment, all patients German-wide. And this corresponds to an epidemiological study, in fact, which we are not very familiar with as cardiologists. But this is very interesting. It gives us really the complete cohort. And this was, of course, non-interventional, observational, but including all these patients. And it gives us a really large cohort of 19,598 patients. And this is the largest WCD cohort analyzed so far. And interestingly, just one final point, interestingly, we had more NICM patients in this cohort than MI cut patients.
So more non-ischemic than ischemics. I understand this is epidemiological observational, but were the doctors given specific instructions who's qualifying for WCD or not, or did they just follow local guidelines?
No, this was just left to the physician's discretion. So, of course, we have some recommendations in European guidelines and also recommendations from the German Cardiac Society, but this was left to the physicians.
Okay, good. So no,
which means this is real world prescription reality. So of course we cannot tell about the patients not receiving a WCD in Germany.
right. And so it looks like the average age was 61 years old. It was predominantly male. So 21% of patients were only female. And at the time point that the WCD was applied, the middle box indicates the average left ventricular ejection fraction was 28%. So that's quite low. And then, so tell us what the results were in follow up to this cohort.
Yeah, maybe let's start with the primary endpoint, because this is what we really intended to show. And the primary endpoint was the incident rate of the first appropriate WCD shock per 100 patient years. And in fact, this, of course, only shows us WCD shocks in the first instance. But if you know how a WCD works, this really means a long cascade of alarms that can be responded to by the patient. And if the patient really doesn't react, then the shock is delivered. So this corresponds to hemodynamically unstable VT or VF. So this is really sudden cardiac death, or if the shock is appropriate and effective, then it's an aborted sudden cardiac death. But this is really otherwise lethal event. The incidence rate for MI cut is 8.6 per 100 patient years, and for NICM it's 6.1. And
so that's time to first event.
Correct.
Time to first event, 8.6 for ischemics and 6.1 for non-ischemics.
And then we have another part of the primary endpoint, which was the overall incidence density of all events, meaning that some patients apparently have not only one event, but several ones. And of course, if this is a lethal event, you want the shock to be effective in all of these. So this describes the overall risk. And of course, we want to secure all of these events. And this was slightly higher, even in NICMs. It was 8.5 events per 100 patient years and 14.9 for MI or CAP patients. This is a high incidence. It's unexpectedly high.
So put it for me in context. First of all, why are we saying per 100 patient years? Let's start with that.
Yes, this is quite a common unit to describe the incident rate. It is the same in other sudden cardiac death registries and also studies, and it also has to do with the fact that usually the WCD is not prescribed for 1 year or 2 years or 5 years, like follow-up was in ICD studies, but it is mainly prescribed for usually 3 months, sometimes 6 months. For this study, our median wear time was only 60 days, so not even 3 months. But this needs to be taken into account if you have an incidence rate, but only have a short follow-up time.
Right. So that allows cross comparison now with the chronic ICD trials, for example. So how does this compare to the incidence rates for the more recent ICD trials?
Yeah, as I said, this was unexpectedly high. If you compare this to older trials, and it's funny that you say recent ICD trials, we don't have this actually. The ICD trials are very old, but if you compare this to, let's say, to a large trial that we still rely on, the SCD study, this is more than double or 3 times higher than in this early trial. So the basement for ICD recommendation are much lower incidence rates that we see here. So the early phase is really a highest risk phase.
Yeah. So, and then if you come down to the bottom right, tell us what that figure is supposed to represent in the bottom right.
It shows time to the first appropriate treatment. And this shows that obviously it's not only the first days, it's not only for the first month. You see events after 30 days, 40 days, 60 days. And this nicely describes that apparently this is a complete phase of risk that we need to secure. Otherwise, these are lethal events.
Right. So very early on for the events. And then in the middle, we see also that there was quite a bit of recovery. Over 50% of patients saw an improvement in the ejection fraction above 35%, irrespective of whether they were ischemic or non-ischemic. And if we can go to the next slide, that maybe explains how we got there. So the GDMT rates in this trial, and this is, of course, maybe in parts attributed to the good care delivered in Germany, but also the guidelines being quite forceful on GDMT rates and a socialized system that has a low copay and no copay for the drugs, because we don't have that in the United States. Our GDMT rates are not above 80 to 90%. So that's quite impressive that irrespective of ischemic and non-ischemic high rates. And the reason to make this point that GDMT rates were so high is that despite GDMT rates being so high, you still had that many events. Mm-hmm. And this to some degree represents a best case scenario. So despite a best case scenario of really, really good drugs, over 50% seem to recover. You still had all these events, and you just told me it's twice as high as in a chronic, most recent SCD trial. If we go to the next slide, I'm just rushing us a little bit through because a couple of minutes left. Now, I really wanted to hit on this one. So I mentioned the improvement of LVEF of greater than 50% in the total cohort. So tell us a little bit about the inappropriate treatments. What are your thoughts on that?
Yeah, we always thought about inappropriate therapies in ICDs and in WCDs. And this just documents, okay, it happens, but it is rare. Look at these numbers, 0.5, 0.1%. So for me, this is a realistic scenario, but it's negligible to think about inappropriate treatments. This is not really a problem. And for me, this is reconvincing.
Yep. And of course, patients went on to receive ICD implantation, but it was now only 36% of those patients that left the hospital with low ejection fraction and risk for SCD that ended up getting it. And then parts was due to recovery, of course, or in large parts was due to recovery, or, somebody determining that maybe we're too low risk. Now, there are, of course, a number of WCDs, at least in the United States. I don't know how the situation is in Germany. But, we talked about, yes, it's extremely wearable. There are potential risks for false alarms, which is why people get those alarms that they can deactivate. But what was the wear time in your WCD trial that you saw in the registered real world environment?
Yeah, it was actually excellent, which of course is a matter also of patient selection probably. But in this cohort, it was more than 23 hours. So really, really good. And of course, the WCD only will protect from sudden cardiac death if it is worn the majority of the time.
Right. That makes sense. To conclude, because we have only 15 minutes total, we're at the end. So you pointed out the results from the largest real-world registry using WCD use, specifically now in Germany. It's a contemporary cohort enrolled over 1.5 years in the last 4 years alone, and demonstrated high use of GDMT, high recovery LVEF early on, yet the risk of sudden cardiac death was particularly clustered in the first 1 to 2 months, was nearly twice to 3 times as high as what we have in chronic ICD trials, representing really the best case scenario, and it still has quite a bit of risk. And I congratulate you to the results of this study and the the learnings yet to come. I would like to point out we'll have another series on November the 4th with Dr. Pam Taub from UCSD in the US. Please tune in. We'll actually go back to the basics, talk about GDMT and sudden cardiac death risk. If you want to claim CME credits, please go ahead and scan this QR code. Tell Dr. Duncker how great he is. And you have a good day. Thanks for the last 2 sessions.
Thank you.
And I would like to thank the hosts of the Heart.org and Medscape. Thank you very much.